This afternoon. I'm Dave West. I'm the deputy editor of Health Service Journal. We closely follow health policy in England, and and I can tell you that from my point of view, it's an extremely good time to be launching these papers. A really busy busy time in health policy, but for good reason that the government's got its call open for its 10-year plan. What probably the most significant development, if all goes to plan, policy for quite some time, at least a decade, if not 2 decades. And so it's really excellent I think that that Pathway's been able to commission these policy papers and to contribute to the development of the 10-year plan right at this relatively early stage, while the government's still got a few months to be doing its work and developing its care models. It is in that way I think an exciting time for health policy, and we can hope that government and ministers are a lot more in tune and prioritizing access to healthcare for some of the most excluded groups, including homeless population. Uh, Prioritizing health inequalities, and I think they truly recognize that they want to prioritize that in their 10-year health plan and their other work on primary prevention in health, which is clearly a part of the government's priorities. But it's also very obvious to us here at HSJ, covering the NHS, that there's going to continue to be some really strong headwinds, countervailing winds, as government and NHS leaders go about trying to put those kind of aspirations into practice. We've obviously had just last week the Prime Minister making clear that the government's overriding priority is for the NHS is waiting lists, and so there's going to be that's going to rise above everything else. And finances remain extremely tight, despite the fact that the NHS is being prioritised above other public services. All the views from locally and nationally in the NHS are that there's still going to be very little money around, spare money around next year and the year after. So while in 2025 there'll be a lot of talk about big and aspirational ideas and reform, which is really important to tap into, and I think these papers are an excellent way of doing that. That it's going to be tough, and again, so there again, these papers are really important for making the case about why this is the right thing to do for both for outcomes and people's experience and for health service resources. I'm very pleased for Alex and Dee to have asked me to chair this, and looking forward to hearing the contents of the papers shortly. What we're going to do is hear from Dee in a second, and then short presentations on each of the papers with some input from people who have lived experience of homelessness as well, and then take questions. But Dee, do you want to give us a short framing for the work that's been done?
Thanks, Dave. I don't think I can do any better than the excellent framing you've already given it. But I do want to say a really big thank you to all of our Pathway fellows and friends who have written these papers. It has been a real joy to work with them all, and I think we have a really concrete, actionable set of policy principles. And what all of the papers show is that the problems are systemic and they are deep, but the solutions are evidence-based, available, and within our grasp. So, with the right political choices, change in this really important part of our public service for the benefit of those at the sharp end of health inequalities is eminently possible. And I think today is a great starting point for that conversation. So, I'll hand back to you, Dave.
Thank you very much. Excellent. And Amina Verity, Dr. Amina Verity, is the exciting task of going first. Amina, over to you.
Thank you so much, and thanks everyone for having me here. For those of you that don't know me, my name is Armina. I'm a GP. I work in Deptford in Lewisham, and I've been leading on a program of work looking at health inequalities locally in Lewisham, but I've also done some research looking at access for GP access for inclusion health populations, and how they've been affected by remote access, triaging, and digital tools that have been introduced since COVID. So I haven't got any slides. I'm just going to give a presentation based on what's written in the paper. So general practice is really at a critical juncture and is struggling to provide more services to more complex patients with less resource. However, time and again, it has shown that it's the best place to deliver holistic, person-focused preventative care that can make a difference for inclusion health populations. Despite pockets of good practice, system change to make this a widespread reality has not taken place. GP access is challenging for all under current pressures, but inappropriate registration refusal for those without ID or proof of address is still widespread in some cases. It's still widespread, and in some cases, new digital pathways have excluded the most vulnerable from the cornerstone of the NHS. This results in persistently poor health outcomes, with people frequently presenting in need of urgent and unplanned care. It also contributes to high frequency encounters, missed appointments, and unmanaged health conditions that drive economic inactivity and early mortality. A systemic lack of capacity and resource for patients for practices in the deep end means that they are so focused on firefighting, they don't have the capacity to think about improving access for inclusion health populations. The GP incentive structure poses a significant barrier, and although central policies state working with inclusion health groups and addressing health inequalities should be part of core business, under the current funding model, working with more complex and multi-morbid patients brings no additional funding and makes practices less likely to achieve full remuneration of the disease management focused targets. The most deprived practices therefore operate with on average 7% less funding and 10% more patients, where we know that that work is more complex and needs increased resource. Specialist services are often commissioned on short-term cycles and are always fighting for their next contract. And in the backdrop of a national recruitment and retention crisis in general practice, staff in more deprived areas are burned out, and where we see the biggest clinical need, the levels of recruitment and retention are lowest. There's a lack of accountability mechanisms nationally to make inclusion health everybody's business, and coordinated population health needs assessment linked to commissioning specialist services are rare. Despite several national policies like Registration for All, the Inclusion Health Framework, and the NICE guidance for people experiencing homelessness, there remains a consistent implementation gap in primary care. The paper lays out the best practice for inclusion health patients in primary care, advocating for specialist services where flexible, longer appointments, continuity of care, holistic, trauma-informed support in low-threshold, multidisciplinary settings, where the onus is not on the patient to chase down support, but the hand reaches out and makes every contact count. We identify in mainstream care great examples of this holistic approach being embedded through the expansion of additional roles at a PCN level, working with populations pre-crisis point to support their housing and welfare needs holistically alongside their medical needs. However, recently, overwhelmed practices have contracted back some of these staff to focus on providing core services, given the lack of funding. There is therefore an urgent need to review GP funding models to reward and compensate practices where they are doing this complex and challenging work. There are opportunities through a population health approach and using primary care networks and the neighbourhood models where we can proactively identify our at-risk inclusion health populations and plug them directly into holistic support in primary care, but it needs to be appropriately resource funded and prioritised by the system. We need to look at the levers of change within general practice and explore why an implementation gap remains on things like registration for all, and work with our primary care staff to give them the support and tools they need to make the right thing the easy thing to do. GPs working in the deep end don't have the support they need, and we need to formalize the skills needed to work with inclusion health and deprived populations. The development of skills training focused on trauma-informed care, addiction management, and mental health support would support the government to retain more staff in deprived areas. If we don't make changes to general practice in a way that's sustainable and focused on those who have the most clinical need, then the NHS 10-year plan with ambitions to shift care to the community and focus on prevention will never succeed. General practice needs to be resilient and thriving in the areas of highest need and delivering high quality, proactive, and holistic care for those who need it most. So, if there was one thing I could ask Wed Streeting to change, it would be to focus on rebuilding general practice through a clear vision that its purpose is to focus on those most at need and prioritize them through the system while building the resourcing, funding, and accountability mechanisms around this. There will be no question that inclusion health populations will be at the top of the list, but it will also work for the whole population. General practice with adequate resource and funding will provide amazing holistic preventative service we're capable of for those most at need, but it has to be funded. Otherwise, all we're doing is asking general practice to do more for less. Thank you. I'm going to pass now to Joanne, who had some reflections on the paper, and she's one of our pathway experts by experience.
Good afternoon, everybody. My name's Joanne, and I'm a person with lived experience of homelessness, chronic health conditions. I've got COPD, and I've suffered anxiety and depression. I find the need for a trauma-informed approach to holistic healthcare. This must be underpinned by compassion, understanding by those who generally care about me getting well. I found myself caught in a cycle of identification refusals, which is said was a requirement. The lack of understanding from professionals who often viewed me through the lens of stigma and discrimination left me feeling invincible and voiceless. Getting help with my idea and other documents and having a healthcare mentor to get me through it would have been really helpful. Not everyone gets this, and if you live in certain areas, you might. Some areas you might not. My own challenging conditions, particularly my COPD, led to frequent, urgent and unplanned care and ambulances. My mental health deteriorated as I felt increasingly isolated. This compounded by feelings of anxiety and depression. If I'd had intervention earlier, I wouldn't have been in those situations. I felt like I was being passed from pillar to post, like a tennis ball at times. Although I felt overwhelmed, I was able to get myself an advocate. Other people may not be able to, however. I am now giving something back to what I took out of the system to make experiences better for others. So solutions, a trauma-informed approach is essential to address these issues. A holistic approach is vital for me. It's a healthcare environment that prioritises safety, trust and empowerment so that I am able to deal with things myself. The NICE guidelines must be adhered to, and the effectiveness of health and local authorities to work together will identify any gaps in services and address specific needs. Charities such as Pathway and Groundswell show improved outcomes when those with lived experience can be involved in improving healthcare. One-stop shops where you don't need to travel for lots of different appointments, especially when you have no money or energy to get there. Embedding mental health and addiction services within practices. It's everyone's business to get people well. Recommendations: the government needs to support GPs to provide appropriate care for those most at risk and provide more funding to enable everyone to do this. A focus on prevention and identifying people and families at escalating risk and supporting them to make changes before it reaches crisis point. Look after our GPs and other staffing services. Less workload, more GPs and staff to provide help and support to people in deprived communities. The good doctors and staff leave because they are bogged down, and the patient then feels mistrust because they have to start all over again. Investing in healthy communities and giving every child a good start in life would work, and recognising fairly if someone in their 30s, homeless, using drugs and alcohol with a mental health or lung condition like me, or any other kind of underlying health condition, help them to get stronger. Thanks for listening.
Thank you very much, Joanne and Amina. A really clear list of asks there to get us started. Well done. Going to hand straight on now. We'll come back to questions at the end after we've heard the presentations, I think. So going to hand straight on now to Dr. Chris Sargent to talk about hospital care from a pathway point of view.
Thank you. I am going to share a couple of slides. Hopefully that's sharing okay. Okay, so I'm going to talk about, my name is Chris Sargent, I'm the Medical Director at Pathway. I'm also a GP at a specialist GP surgery for people experiencing homelessness down in Brighton, and the GP lead for the Pathway team in Brighton as well. So I'm going to talk quickly about secondary care policy. So first of all, what's the position at the moment? What's the problem we're trying to solve? So at the moment, we've got a situation where people from inclusion health groups and homeless people are coming in repeatedly to hospital, repeated hospital attendances.
I needed to ask about this before I sent.
I think somebody needs to put themselves on mute. When people are admitted to hospital, they experience stigma and discrimination and a lack of understanding from staff about the issues that they're facing. There's also poor practice when people are in hospital, so their substance issues aren't treated in a timely fashion. People go into withdrawals and leave the hospital before their treatment is completed. Not enough attention is given to mental health issues when people are admitted. So this leads to issues with people discharging themselves from hospital. So self-discharge rates are very high in inclusion health groups, and discharge to the street can often follow as well, because people don't understand the difficulties that people are going to face when they're discharged from hospital. We have very good guidance. It's not followed. So, and we know that things like discharge to assess don't work well, are not made to work well at the moment in our populations, and that duty to refer is not done in many places. So that's the duty on a hospital to refer to the local authority housing department if somebody experiencing homelessness is admitted to hospital. That's often not followed unless there's a specialist team in place. And there's not enough following of the evidence-based interventions that we know do work. So pathway teams and intermediate care step down can really help to make sure that the admission does all the things that it can for the person, that they have holistic care when they're in hospital, and that then they can be discharged in a timely fashion once their treatment is completed. There's also a situation where there's poor joint working across different services, particularly between hospitals and community. So what do our policies need to do? So we're suggesting that we need to make trusts assess themselves against best practice. So the NICE guideline 214 and discharge guidance that's available, and to audit themselves about what's happening with self-discharges and discharges to the street. At the moment, we're in a position where generally we don't know what's happening, and hospitals don't know what's happening in their own institution. We want policy to make trusts appoint senior leaders, so have an inclusion health director on the board of every acute trust to make sure that inclusion health issues are obvious and raised with the board, and that the audits and the extra work that we're asking for happens. So there's somebody responsible for making that happen within the trust. We're suggesting we need policies to target to reduce self-discharge and increase GP registration on discharge. Obviously, we're talking about different areas today, but everything's linked, and it's important that hospitals act to make sure that people have follow-up when they leave hospital. So one of the important things there is to make sure that there's registration with a GP so that the health and care issues can be followed up on discharge. We'd like the government to have a policy to fund a safe discharge programme. So that's increasing the number of pathway teams where they're needed in hospital, or other interventions where pathway teams are not needed, and intermediate care step down expansion. I think somebody else is going to talk about intermediate care step down, but again, it's all connected. So we need this safe discharge programme to increase those interventions that we know work and improve health outcomes. We're also calling for a policy to work with the Royal Colleges on education and training for all. As Joanne said, when people are in hospital, they often suffer from stigma and discrimination and a lack of empathy, and that means training up everybody who works in a hospital to know about inclusion health and be able to treat people appropriately. And we're also calling for the inspection regime to inspect against best guidance and best practice in inclusion health as a priority, because if we can make things work for the inclusion health groups, it will work better for everybody.
Let's double up.
So I was also asked to say, what would I say to Wes Streeting if I was stuck in the lift with him? So I think I would say we need to stop discharging people from hospital to the street. We know how to do it, and we'll show you how.
Excellent. Thank you very much. So even if you were stuck in a lift for a very short time, you'd get your point across there, which is the absolute name of the game. So thanks, Chris. Now passing on to hear about mental health care from Dr. Jenny Drive, who's a specialist psychiatrist. Jenny.
Hello, yes, I'm Jenny. I'm a psychiatrist in a community mental health team for people sleeping rough in South London.
Really get an idea of how soft and
someone's got their mic on. Anyway, so I don't have a slide, I'm sorry, and I don't think you can see me. It was quite a daunting task writing the paper because there's quite a lot to be said about mental health. So if I haven't said what's important for you, I apologise. But what I wanted to get across is that rates of mental illness are very high for people on the streets. About 80% of people report mental health problems and 50% have a diagnosis. And that's not just because sleeping rough is bad for your health and your mental health, although that's undoubtedly true. It's because mental illness leads people to the streets and stops them from getting off them again. So any government plan to decrease or end homelessness needs to have mental health care at the heart of it. And first thing to say is that most mental health care is done in primary care. So what Amina and Joanne talked about at the beginning is really crucial for this. And if we got that right, it would make everything easier down the line. GPs are really key. And when people go to secondary care, it's the same things that are important. So we need to make sure that the most vulnerable people are given the highest priority in mental health services. That means people can't be excluded from mainstream services because they're homeless, either overtly because they don't have a GP or an address, or structurally, for example, because of digital exclusion. For those who are under CMHT care, but CMHTs are failing to engage, there needs to be easy access to early intervention services who can intervene before people become homeless. But some people will end up on the streets because of the nature of the mental illness, and those people need to have specialist teams who can intervene quickly to get them off and into good quality housing. And there's plenty of evidence in the recent NICE guidelines about what works for those people and what those interventions should look like. So those guidelines need to be followed by trust and followed by commissioners. Crucially, though, it involves joined up work with social services to ensure that Care Act assessments can be done quickly and people can get into that housing with support as they need. It's also inevitable that people will sometimes be admitted to hospital. When that happens, we need to maximise what goes on in those admissions so that they only happen once. And as Chris said, discharge to the street should never happen. There needs to be more training for everybody involved in mental health so that they understand the difficulties of homeless and inclusion health. And that should particularly include questions of capacity. My second major point in the paper was something that Joanne also touched on earlier, and it's that we need to end the divide between mental health services and substance misuse treatment. So many, not all, but many people on the streets have got substance misuse needs in addition to substance misuse needs in addition to mental health needs, and those people are often the most vulnerable. They've often got histories of severe trauma. If we can't reunite services, we need to ensure that substance misuse services are commissioned to assess and treat low-level mental health problems, and that they've got easy referral routes into the community mental health teams for the people who need it. No one should be excluded from mental health services because of their substance misuse. Similarly, mental health services should be able to assess substance misuse problems and provide brief intervention rather than telling people they need to go somewhere else. And that's my main message to Wes. Is the title of my title of my paper, that we need to see and to care for the whole person. By that I mean that it's more effective and more cost effective to look at someone holistically in a way which is trauma informed and treat their coexisting problems together. As much as possible should be done in one place. But I also mean that we need to think about why those problems developed in the first place, and very often they have their roots in childhood trauma and ACEs. So to reduce homelessness and mental illness and substance misuse in 20 years' time, we need to do everything possible to reduce inequalities for children now.
Okay, thank you. And I think I've spotted that theme of inequalities for children in a couple of presentations so far. So questions are coming to my mind, and if other people have got them, feel free to note them down, or I think you can just put them in. We'll take them at the end of all the presentations, but you could put them in the chat, the team chat now, I believe, the group chat, so that people can start thinking about those questions, and I'll kind of field them at the end. But next, going to hand over to Jill, to the first one of our two Jills, to Jill Taylor, to hear about safeguarding. Jill.
Hello, everybody. Like a couple of my colleagues, I also don't have any slides, and I was meant to. In fact, I think it was me that said we should have them. But the reason that I don't is because instead of making a couple of slides this morning, I've spent the morning, I'm currently in the Museum of Homelessness, talking with people here about someone who died earlier this week from our community. And that is what my paper is about. It's that the consequences of all of the things you've just heard my colleagues say is that 1,474 people died whilst homeless in the UK last year, at least, and many more besides. We can count many other different statistics across Inclusion Health to speak about the ways that the failure to safeguard people by providing them with good healthcare costs their lives, as well as our money and the resources and energy of our frontline staff. It simply has to change. Everything you've heard everybody else here say today, and that you'll hear people say after me, is ultimately and always about keeping people alive so that they can then have good lives. But if we don't keep people alive, then all of the other things we're talking about here don't matter. And safeguarding is the mechanism that we have to do that, but it is woefully insufficient. The Care Act was written just over 10 years ago now, and at the time was a transformational piece of legislation, but it is old and it doesn't include inclusion health populations. As a result, I think what Amina was saying is things that should be easy are not. The hard work should not be trying to get our colleagues in different organisations to respond to our emails because they're under so much pressure that they can't respond to the things that we need. It shouldn't be the case that we're talking about lifestyle choice as a reason why somebody living with self-neglect and a brain injury is on the streets and dying there. But it is, and it is because the mechanisms within the law and policy continue to exclude inclusion health populations, even as we're trying to bring them in. The Care Act is a blunt instrument at the moment to support the people who live outside because it simply doesn't speak about them. And although we might try to find ways to make it work and navigate it, it doesn't work. So my paper, which hasn't been published today with my colleagues, but will be, and that I'm writing with Jamesy, who's on the call here today, is going to make that point that we simply need new legal tools and new policy documents that speak to the actual populations we're talking about, instead of what we all have to do here, which is to try to fit them in like a round peg in a square hole. The Care Act must talk about rough sleeping. It must talk about the responsibilities and duties that we all have to make sure that people don't die on the streets. And that includes things like making an immediate commitment to ending discharge to the streets from hospital and from prisons that we know kills people within weeks. It also has to make commitments from across government around ending deaths as a major policy commitment. It cannot simply be something we assume is implicit because we all know that it isn't morally fair. We have to say it, and government must say it. And beyond saying it, we have to have the resources that enable that. Inclusion health can only function if inclusion health is resourced. And when people who are living in inclusion health populations are turning up at hospitals with things they should have been able to go to their GPs about and then dying from those things, you can see how the whole system of safeguarding can only function if every part of it is resourced effectively to do that. And not for me to say that simply everything must be better all the time in my paper. I can't write that, and I haven't written that. But without making the really clear commitments, not just to each other as we do in these rooms all the time, but from policymakers in central government and across their departments to end the premature deaths of people who are homeless or from inclusion health populations, then we can't move this forward. So if I was in a lift with Wes Streeting, I would have many things to say. But one of the things I would say is that you must say it, that we want to end the deaths of people on our streets, in our hostels, and that the only way to do that is to enable us through law and policy by making those commitments, by ratifying them in law, and by making them mandatory rather than just nice to haves on the edges, which is so often the case for our populations. And I'll stop there because otherwise I'll talk on and on forever. But thank you very much.
Thank you, Jill. Very powerful and clear. And over to Jill Lang.
I'm just going to try and put my slide on, see if this one works. Is that on the shared slide? I quite often have problems. Someone at Pathway have it. Sorry, guys. I sent it for this reason. So I'm Jill. I'll just crack on if someone could find my slide in Pathway. I've got the unenviable task of trying to fit the whole topic of housing and populations and inclusion health groups into the wording that Dee gave me, and also today's time limit. So I'll just begin with saying my paper presents the case for the home circumstances of people in inclusion health populations to be considered in the planning, design and delivery of healthcare. It makes the case for national housing and homelessness policy, legislation and funding to reflect that, especially for people in inclusion health populations. Housing is a health-related service as defined in the Care Act and the Health and Social Care Act 2022. And it hopefully makes the case for the 10-year health plan, the long-term strategy for housing and strategy to end homelessness to together provide the conditions for successful and sustainable integrated health, care and support and home solutions for people in inclusion health populations. Since 2006, successive governments, their strategy for the NHS has been care closer to home. But from what I can see, there has been no consideration to what that home might look like, and particularly not now we're in a national housing emergency, and of the national housing emergency that Lord Darzi referred to in his review of the NHS. Does our home environment enable someone to successfully manage their health and care condition whilst living at home? Does it support recovery following a hospital admission? Does it provide a healthy, warm, suitable virtual ward? For many people in inclusion health populations, their housing circumstances couldn't be further from providing the home environment assumed in care closer to home. Precarious housing is the common experience, but so too is cold and damp, overcrowding, unsafe and unsuitable housing. These circumstances do affect access to, experience of and outcomes from healthcare. Living in a precarious situation is incredibly time consuming and someone's capacity is impacted. They may not have time to access healthcare. And alongside barriers such as access being wrongfully denied if someone has no proof of address, short notice house moves, often to locations away from support networks and outside existing healthcare services, place additional demands on people who may face then different thresholds for access and waiting lists for treatment. Some people, including families, are simply lost to services. And if poor living circumstances aren't understood in delivery, then experiences are impacted. If medicine is prescribed that requires refrigeration or safe storage when this just isn't available at home. If the stress of living in a cold, shared, noisy, chaotic house with strangers is not understood in the treatment and recovery of someone with mental ill health. And if it's not possible for someone to use technology at home. If there's not this understanding in access and experience, it's reasonable to assume we won't see positive outcomes from this care. And if people continue to live in unhealthy circumstances, their ill health, and particularly mental ill health, will continue to deteriorate and possibly lead to new issues. For people in inclusion health populations where they live, it's not just a wide determinant. It is a matter for healthcare public health. Home circumstances must be considered in the planning, commissioning and provision of healthcare services. And crucially, healthcare public health is an NHS function. We're not starting from a blank sheet about how we might consider the home environment in the design and delivery of healthcare and how people and organisations might work together. The Care Act and Health and Care Act both describe housing as a health-related service and provide the framework for the integration of health and care services with health-related services. And we also have the NICE guideline that colleagues have mentioned previously. What we don't yet have is national housing, homelessness policy legislation and funding that reflects the same level of understanding about the relationship, which in turn presents significant barriers to integration, even when localities want to do this. Positive practice is despite the environment, not because of it, and is at continuous risk from disinvestment. And as Jill mentioned, gaps between and within housing, homelessness, health and care legislation are gaps people in inclusion health populations repeatedly fall into at a cost of their health and wellbeing to the NHS and other public services. The development of the 10-year NHS plan, long-term strategy for housing and strategy to end homelessness, we have an opportunity to do things differently and for these to share an ambition and outcomes for better health through homes. The evidence of what works and what we've learned of the systemic barriers for integration for people in inclusion health populations suggests what those right conditions might look like. Local integrated housing, health and care strategies supported by a single pool budget with an initial focus on people from inclusion health populations, but related to other populations who are already a priority for the government and the NHS, for example, people with a learning disability and autistic people. It would look like routine assessment of the impact of national and local housing policies on healthcare, and it would look like the routine assessment of health and care policies, thinking about people whose home circumstances simply aren't those envisaged in care closer to home. It would look like investment in people, and specifically in local, national and regional housing leadership capacity and capability, and in public health to enable integration. And it would look like the inclusion of housing and homelessness workforces in national and local health and care workforce planning and development. It would look like national infrastructure to enable localities to develop a shared understanding. And the next presentation talks a bit more about that, what it looks like in more detail. But crucially, it would look like a long-term strategy for homes, not housing, that ensures equitable, not equal, equitable access to affordable, healthy, safe and suitable homes, providing the social homes needed, particularly with accountability in place to make sure that they benefit people from inclusion health populations. It would improving the private rented sector with a particular focus on the lower end of the market and the shadow PRS. It would mean enabling additional supported housing to meet a range of needs, but particularly for people who need long-term support. And where temporary accommodation is needed, it would mean improving standards, providing wraparound support and offering other reasonable adjustments. I suppose my final point is that it isn't just an opportunity to improve outcomes now for people in inclusion health populations, by acting to fill the gaps that we know exist between siloed systems and services that people in inclusion health populations experience, and often from childhood. We will all benefit from better quality healthcare, from better use of the public purse, from our workforces feeling that they're making a difference and are valued, and we will all benefit from better homes. Thank you.
Thanks, Jill. Do you want to have a go about a quick message for Wes? Or...
No one knows I don't really do quick. Well, I think homes in all health policy and health inequalities in home policy. I think even if the two just did that, if they that would be a good start.
Yeah, I think it strikes me that certainly the care closer to home is a huge buzzword in the sort of health policy and NHS leadership again at the moment, isn't it? So that's a good way to kind of get into this agenda. And neighbourhood as well, I guess, is another slightly a word which points you to, well, what home and what neighbourhood might be useful ways to keep raising these issues. And now pass on to Theo Jackson, who's going to present paper on data.
Hi everyone, I'm just going to share my screen quickly. Is that coming through okay? So hi everyone, my name's Theo Jackson. I work at Pathway as research and data lead. Just a couple of quick notes before I start. I was going to be joined by Sahar, who's a member of our lived experience program. She unfortunately can't make it today. And in fact, the paper on which this presentation is based was written by Sam Dorney-Smith, who is a name that will be familiar to many of you. For those of you who don't know, she's spent a lot of the past 10 to 15 years being very involved in a lot of the thinking and improvement and development around inclusion health data. So this paper really draws on her expertise. Just starting off with a really quick bit of background and thinking about how we normally understand inequalities in health data. Obviously, it's essential for identifying inequalities and also monitoring progress. Usually, we pick these inequalities up in relation to core demographic data, ethnicity, gender, and so on, or in relation to geographical areas, so postcode, regions, etc., etc. And this really shone through in COVID, where we identified really big differences in COVID outcomes for different ethnic groups and geographies. Obviously, the two of those being related. When we think about inclusion health groups, however, the problem is we can't use these categories to actually identify the individuals who are in these groups. So, for example, if you think about an individual hospital, it's very challenging in general to go into the data for that hospital to identify which patients were experiencing homelessness, which patients from different migrant backgrounds, etc. So these patients are essentially invisible within healthcare data. Some of the reasons for that, some of the main ones being homelessness is not routinely or consistently coded across healthcare settings. Housing status is rarely recorded, and where it is, it's done very inconsistently. So this is the problem that we're facing. The impact of this is that people are therefore invisible to the decision makers, and this plays out in a few really important ways. Firstly, it really limits our ability to understand the population through targeted needs assessments, and that's really relevant to ICSs in particular, targeting and understanding their local inclusion health populations, which makes it very hard to commission services that actually meet those needs and meet the level of demand. Has negative consequences for wider policy development, so looking at the trends on a national scale, developing policy responses, and also looking at the actual impact of those policies. And two things which have come up in the previous presentations, accountability and funding. So the lack of data makes it very hard to hold the system accountable in terms of inclusion health populations. It's very hard to set top-down targets for inclusion health when we don't have the data to actually understand and monitor progress. And it really links to funding as well, which is something that has come up very strongly. In a very simplistic way, to unlock funding within the system, you need to put numbers in, you need to put figures in. The lack of data can be really challenging for unlocking the funding we need for inclusion health. So our proposal, I should say there are different ways to think about kind of improving inclusion health data. The proposal we're putting forward really focuses on improving the recording of housing status across different healthcare settings. There are quite a lot of reasons why we think this is important. Firstly, the link between health and housing, as Jill's just talked about. It's a very good proxy to capture people in inclusion health groups who typically all experience housing precarity, useful for wider health inequalities work. I won't go into too much detail about what SNOMED codes are, but basically there is a coding language which sits underneath all other coding languages within the NHS, and the codes exist for lots of different types of accommodation. The main point there is that there is development work that doesn't need to happen because these codes already exist. So technically, it's very, very realistic to do this. In terms of progress that's been made so far, there's a standardized list of housing fields that was produced in 2018 with the organizations you can see listed there and lived experience groups as well. And that's a list of different housing fields which strikes a balance between being detailed enough to be useful for research and analysis, but also being practically usable by the people that will be actually putting the data in different healthcare settings. So over the past years, we've had some success at Pathway of getting this rolled out into different healthcare settings. So it's now been partially implemented in the emergency care data set, which covers A&E settings, and in the mental health data set as well in England, which covers mental health settings as well. There's also a lot of ICBs in this. So our recommendation really focuses on taking the work that's been done already and pushing it forward. And we have a very concrete and well-defined ask in terms of this. Firstly, is to understand in the short term how these existing housing status changes are actually being used. Are they being used, and what is the preliminary data telling us? In the medium term, it would be to take the information from this stage and to establish a major pilot of the use of these housing fields across different healthcare settings, so hospitals, general practice, community teams, wherever you can get involved, ideally with some kind of academic support and input as well. And in the longer term, we'll be taking the learnings from the first two steps and implementing a major program of reform across the healthcare system. So we really think that improving the recording of housing status will allow us to more accurately identify the individuals and populations that we're interested in, and that will really help us to drive improvements for those groups as well. So I think the one ask of Wes, as well as implementing this this very structured recommendation, I think the one ask of Wes would be to provide the sort of top-down national leadership that's really needed on this issue. It's an issue that would need to bring in lots of different parts of the system, NHS Digital, NHS England, for example, ICBs. So the ask of Wes would be to really provide that top-down leadership that's needed to make progress in this area.
Thank you very much, Theo. And that brings us to the end of the presentation. So we've got a good amount of time for questions and comments that if people might want to make, you can put them in the chat or put your hand up. I think we can probably just hear from you directly if people want to put a hand up for questions. I'll just say so Armina, I think, has to leave at past, so I will get in with a question for you in a second, but also just to say that I can see the papers have now been published on the website, so they're live as we speak. Can't go and read them yet, but after the session can get reading and sharing. So please do that. And let's see, this question or comment has come in from Reese Ward. Reese, do you want to sort of unmute and talk and see if it works, or do you want me to? If you don't, then I will carry on reading your.
I can try. Apologies, working from home today. My child's off sick. Yeah, no, some fantastic presentations. Thank you to everyone. Loving the message to Wes. Idea, obviously, trying to drive change now where we are is crucial. Just as a commissioner, looking to just try and understand the backdrop of all the fantastic work you guys have put in to get to this point under previous governments, etc. I know we've covered different demographics, which is incredible. Lovely thought process. Yeah, just wanted to try and quantify that from a commissioner mindset and the data and the analytics that's gone into that. If I may.
The work so far. Okay. So Armina, could I put you on the spot on that about your perspective on what's been how services have developed over the last period?
Yeah, I guess I think there's been quite a significant amount of policy change in the last kind of 10 to 15 years, with like most recently kind of publication of NICE guidelines, the Inclusion Health Framework, having the National Healthcare Inequality Strategy, so giving us this kind of definition of Core 20 plus as like a focus of a population we should be thinking about for health inequalities. And a lot of that was really driven forward post-COVID. And I think people really woke up to the reality of how significant health inequalities were playing out. I think, from a primary care perspective, definitely what we've been trying to unpick in the paper was there is this implementation gap, which is basically related to a complete lack of capacity to kind of engage with those programs. And often, so when I started working in this area, there had been for I think 3 years before COVID, to 2018 maybe, it came in a PCN requirement for a health inequalities lead in every primary care network. And the amount of people that actually were taking up that job was very, very low, because there was no funding, no resource, no community of practice, nothing driving it, no accountability mechanisms. And as sort of post-COVID, that's some places have pushed forward in those areas, but it's not sustained, it's not coordinated, it's not driven, and there's no accountability to do that. So a lot of these national kind of policies and procedures just aren't being translated on the ground. And increasingly, when you look at very in practices where they have high proportions of inclusion health populations, or areas where there's significant amounts of deprivation, they just cannot move beyond keeping the lights on in some cases at the moment. It's really, really dire out there. And so trying to add in extra things that are seen as extra rather than that are seen as core is the key thing. So the rebranding of kind of how we say general practice, I think, is we need to look at saying it's okay to not provide appointments for everyone as long as you're focusing on this population, and then that if we can define that and say this is medical need, then we can start making change, I think.
Prioritizing particularly urgent care, or prioritizing all GP?
I think for
really?
everything, proactive, preventative, I think you can then talk about proactive, preventative care. If we have that data statement, as in Sam's paper, then we can say, okay, we don't need to wait for these people to come in crisis. We can proactively go and reach out to them, and then we can give them a holistic offering and develop that, and then see what we can do, and really provide that support, rather than waiting for people to happen to manage to navigate, to just about get an appointment, to just about then be asked to come back again. If we said, okay, we've been told, we've been tasked with continuity of care, prioritizing this patient population, then you could build your whole system around that and it'd be really easy. At the moment, we're trying to do that whilst being told access for everyone above everything else. And you just can't do the two things at once well.
Permission to prioritize. Okay, lots of hands going up now. So I'll go first to Nicola Glassbrook.
Hi, good evening, everybody. At the risk of getting shot down and being too simplistic, I feel like I'm having different conversations in different rooms. So last week I was at a really useful community of practice around trauma-informed care, or, introducing trauma-informed care. It was headed up by Surrey and North East Hampshire, ICB, who've been, they've taken it upon themselves there, two women, to do a lot of work. Jill's nodding, so I guess you're aware of this. But it just feels to me as there not some way we can pull these two conversations together, in terms of what they're asking for is a national strategy around trauma-informed, because, as you know, it can mean different things to different people. And I think some of the things, certainly within our system, we're wanting some agreed sort of principles around that. Because I think what we're talking about, and this way is when we're talking about, inclusion health, it is about trauma-informed care and all the components of that. And I'm just thinking, is there a useful to have a bit of strength in numbers and actually kind of support each other to push for the same things?
Uniting the effort, yeah. Okay, I expect some people might be able to come in on that, mightn't they? So, Alex, I think you're up next. You're muted at the moment, but
sorry. Thanks for that. Thanks, colleagues, for some really, really fascinating presentations. I knew it was going to be an interesting afternoon, and such it has transpired. I was thinking there's a theme across the conversation with Wes are interesting, because the conversation with Wes means that we're all hoping that someone who's our master is going to tell us what to do, and issue some directions, as it were, which I think there's place for. But I just wondered, I think, Armina, you've talked about this and thought about it quite hard around the role of incentives in primary care. Is it money which makes people do things? Is it exhortation? So just wondered, and Jenny also, that balance between, I suppose it's the balance between training good practice and building up good people, or top-down strategy. I mean, Jill Taylor, you talked about we need some clear mandates of things which should just become unacceptable. But we also know from the reality of life, we also need people who are motivated and want to proceed and do the right thing, if you like. So what are colleagues' thoughts about that? What would our dream Secretary of State be doing in terms of setting that balance right between mandate and, people have used that word, of giving people permission to do the right thing at the same time?
Once they've Jill Taylor, do you want to come in on that? And you had your hand up before that as well.
Thank you. I mean, suffice to say that as a rank and file socialist, I wouldn't have a Secretary of State, but notwithstanding my political position on the matter, I think that one of the things that is too easy is to locate the problems in frontline practice. And I think actually, if you look at the evidence, it tells us the problem is simply not in frontline practice. It's that frontline practitioners can't deliver what they know is needed because of everything else around it. And so I think it was Reese who asked the question about what goes behind this. I think what we've seen for the last 20 years is small incremental changes that make us, to some degree, feel as if we should be able to do good work. But in reality, that isn't underpinned by the kind of resourcing, the kind of law, the kind of national policy commitments that we need. So we end up with these, to paraphrase Pathway, pockets of excellence everywhere that are driven by incredible people working far too hard, far too many hours, causing themselves untold moral injury and distress, instead of the work we know we want to do and are able to do being possible because we have the structures that support that. And every bit of the evidence tells us that. My paper is about safeguarding. We've been doing work looking at the deaths of people experiencing homelessness for just shy of a decade now. And we see the same challenges happen over and over again. The same reasons why people die 10 years ago are the same reasons why they die today. That hasn't changed. It's only deepened and become more entrenched. So I think hopefully what these papers do is reinvigorate a conversation that's already been happening, but at an opportunity for the new government to reverse some of the damage that has been caused over the last 15 years. And whether Wes Streeting does that out of the goodness of his heart or because of the pressure of all of the people in this room and elsewhere, I don't know. But I think it's something about reminding policymakers at this key point that this is an opportunity not to forget, again, this group of people who desperately need better policy. And that is probably enough from me.
Thank you. So I think Jenny, I think had your hand up next. Jenny, if you want to.
Yes, just going back to the original question, I think there was a lot of interest by the previous government. There was the rough sleeping strategy, and there was a lot of sort of investment in teams that work with people who are mentally ill and on the streets. And so there's a question about why then numbers rough sleeping still go up and why that isn't enough. And I think one of the things is that interventions that are known to work aren't just embedded into national practice. So whenever there's a new government or there is a new renewed interest in this, someone sets up a scoping exercise and someone says, let's have a pilot. And I think the time for that is past. I think the NICE guidelines say what should be done. So then, as Alex says, the question is why doesn't it get done? And like I was saying about coexistence, substance misuse and mental health, that people have been saying that for at least 10 years, the guidelines saying there should be no wrong door and you should get help wherever you need it. And it just doesn't happen. So it needs a top-down approach, I think, to measure whether it's happening within trusts, and people need to be measured upon it and some sort of sanction if it's not done. And equally, as you say, there needs to be more training for professionals as they're going through, so that these things aren't viewed on with kind of horror and people saying this isn't anything to do with me. But I think I think we don't need any more people saying, oh, I'm really interested in how to end homelessness. I have about, several conversations like that a month, and we know what to do. We just need some power to do it.
Okay, thank you. Yeah, I was struck by some of those points about the NICE guidance and long and often going unimplemented. I think there is a bit of interest in the new government, in the Department of Health, in sort of revisiting things that they can ensure are done once, and looking back to national service frameworks that they had in the 2000s. But of course, I guess the key is to get into that process and be involved in one of those national service frameworks, perhaps. Amina, have you got your hand up before you still need to leave in a few minutes?
I just thought I'd just come back on the incentive question from Alex before I go, just to so I think for primary care, the problem is that at the moment it's death by 1,000 cuts. Like, the amount of things that are being transferred into primary care anyway is really unmanageable. The level of funding just hasn't matched the demand that we need. And so anything that is additive in the current climate, I think, will not work. And I think it has to be that reprioritization if we're not going to increase capacity massively. And we know that 10-year plan is going to take, 40 years to actually get underway. In the immediate instance, that we could do really great work in just reprioritizing and giving people permission to focus on specific populations and redressing that balance of the inverse care law, and just saying, okay, actually, let's stop asking the places that are doing more complex, difficult work to do it with less, and let's actually just fund them a bit more and redivert a bit of funding. It doesn't have to be additive. It can just be like redressing the balance. And then if we give people that little bit of capacity to be able to do that, and you're not on a losing streak where if you have a complex multi-morbid patient, you're paid 0 extra to look after them. And so it's like, it just doesn't make sense. It doesn't make sense for inclusion health populations, but also doesn't make sense for frail elderly populations as well. And so it's that thing of like, how do we, it could be the same story that we tell for how they resurrect the NHS anyway. So I think it is a really key thing, and they could just reverse some of the really perverse incentive structures that exist now and make quite significant gains.
Slightly more proportionate universalism, slightly
exactly
towards that. But it's
so sorry I have to go. I really wish I could stay for the rest of the discussion, and thank everyone for
thank you very
having
much.
me here. Sorry about that.
Thanks for your excellent input. Yeah, it's one of the things that I've noticed in this reform program, this 10-year plan discussion so far, compared to the last few 5-year forward view long-term plan, is the government talking a lot about the ministers and officials talking a lot about this engagement, and actually spending a little bit more time actually doing it. But not only that, but talking about though I don't think they've done it yet, they do claim that they're going to talk to people about difficult trade-offs and prioritization, and while the health service won't be able to do X, Y, Z, so it will have to focus on other things. So that's really difficult, and the public might not come back or kind of come back with the sort of things that we'd want them to, or that everyone would necessarily hope for. But it does create an opportunity maybe for what I'm talking about, prioritizing people who have less agency and more need potentially. But Chris, you had your hand up for a little while. Go for it.
Thank you. I was just going to go back to the question about what makes people actually implement guidelines and follow guidelines. And I think prioritization is one of them. People knowing that it's the right thing to do. I think generally people in health services do want to do the right thing. But it's also giving them the resources that they need to do that. So with the NICE guideline, with the discharge guidance, if people look at the discharge guidance and it says to do a particular thing, but they don't have the resource. So if it says there should be a specialist intermediate care step down for people to go to when they're discharged from hospital, and there isn't one, then they just kind of revert to, well, what's going to solve this problem quickly then? And I think it's got to be people being told that they need to do the right thing, having the guidance to follow, having the resource, and then knowing that it's a priority in the health service as well. At the moment, I think the message is very strong that people experiencing homelessness coming out of hospital, people from inclusion health groups, are not the priority. And there are other things that will outweigh doing the right thing for them, such as making sure the beds aren't blocked, making sure that there's not extended lengths of stay. Those things are a much stronger message in the health service at the moment. So if we do want the health secretary to do something, I think it would be to say this group is a priority. Addressing these extreme health inequalities that this patient group suffer or cope with is the real priority for us. And the numbers of people are not that massive, and the gains to be had are extremely high, both health gains, but also gains for the health service. I think that's probably the message overall that we would want to get across, is allow this to be a priority.
Okay. Tony Jablonski.
Yeah, I'm not sure you can hear me. I'm looking from the outside in, and I'm just concerned that there's a suggestion that there should be internally more directors of inclusion health, because I'm not sure that's going to have the desired effect and could be an overhead in costs. I would have thought it would be better to have people external to the NHS monitoring and assuring a certain amount of governance. But be that as it may, I think that there needs to be a change of direction in policy, which everybody here seems to agree, because when I've looked at the spending in the NHS, it does cycle between about 10, maybe 11 and 12% like many European countries, but the outcomes are not as favourable in many important areas. So therefore, I don't think it's a question of money and extra revenue supplied. It's a more reallocation of resources, which hopefully people are going to capture in their papers. And I'm quite shocked that a lot of GPs and even doctors in hospitals don't seem to do very much postgrad training, and I think that needs to be a necessity in terms of inclusive health. I think that would really benefit cross-working teams an awful lot and improve the awareness between some GPs, not all obviously, but I think more emphasis in both the undergraduate and some postgraduate training needs to be done in inclusive health to make just the profession more aware of the need. My view very much is if you fix it at the bottom for people that are highly excluded from the system, you'll improve it for everybody, including those fortunate to be at the top of the system. Thank you very much. Thank you.
Absolutely. Thanks. Tony, yeah, I think working with the Royal Colleges on this sort of training was part of one of the recommendations of Chris or Sophia. Mandy, you've got a hand up.
Oh, sorry. Thank you, Dave. A couple of points I just want to raise from what's been brought out from the papers. And I think it's like we've touched on the NICE guidelines, do you know what I mean? And it's like they tick along in the background, but they're not really took that serious. And do you know what I mean? As Jill touched on, there's people's lives at stake, do you know what I mean? So I think there should be a bit more legal requirements set along the NICE guidelines. And I think another thing, I think the big ask for me for Wes would be that you've got these people here today, these charities, the Voices of Lived Experience, that have searched for many, many years to find the answers. We'll have the answers. Do you know what I mean? It's just time. We've got a glimmer of hope with the new government, maybe. Do you know what I mean? And it's time that the action come from someone else. Do you know what I mean? You've got burnt out staff in charities, in hospitals, GPs. Do you know what I mean? It's time that government took responsibility. We'll have the answers. You hear it today in all the policy papers, the fantastic work that, you know what I mean? People on this call go above and beyond every day. Do you know what I mean? I think it's just now time that we had a government that actually cut with some slack and listened and started to implement what we know will work. And not just that, save lives. That's the most important part. Do you know what I mean? We heard today, you know, you can hear the pain in someone's voice. This is the reality that we face daily, you know, and that's all we're asking for is bit support to get this done. And the ideas suggested, implemented. But thank you, everybody, for everything you've done. Thank you.
Thank you, Mandy. Jill, did you want to come in on that? You had your hand up briefly, but you've...
Did I? Sorry, I didn't
Oh,
mean...
you didn't. You weren't. You're just agreeing. Okay. I wonder, Theo, if you wanted to come in on the point about inclusion health directors and just, you know, there was, I think Tony raised the issue about what the role is, and I'd be interested to hear more about sort of examples where it works and where it strengthens organisations.
Sorry, was that inclusion health directors?
Yeah.
Yeah. I mean, I'm not sure how much I can say about that, to be completely honest. I mean, I think just some general reflections and trying to pull points out of Sam's paper. A lot of what we're talking about, I think this accountability point is so central, and talking about how to incentivize people and how to incentivize change. Obviously, that accountability point is really, really fundamental to that. And if no one's monitoring or evaluating, there's so much less pressure to actually change things and change practice. And I think that's probably true. I mean, you can think about that at the level of an ICS, for example. You can also think about it at the level of an individual service, that lack of accountability at all levels, and then obviously on the level of national monitoring as well. I did want to pick up on something that was just said, and I think that's something quite interesting that Mandy said, which is also about the role that the third sector plays in all of this as well. You know, a lot of this work going on in the third sector, this fantastic work. And I can't remember what I was reading the other day, but it was about how very often third sector and community organizations might have better connections and links to people to actually engaging people, whereas healthcare services might be slightly removed from it. There's a need to work together. But I do think it is a really interesting question. I think Pathway finds itself in this position quite a lot. The extent to which the burden of this is shifted away from government structures and centralized structures and onto the third sector, which, you know, faces its own set of resource constraints. And I think that's a really interesting question, because obviously we have an important role to play, but there is, I think, a really important sense in which we can't continue to pick up the slack for a system that should be doing those things. So I think we find ourselves in quite an interesting position. My personal perspective is that the third sector does too much, and a lot of what the third sector does is actually the responsibility of government. I see some nods there. So not really answering your question, but just some general reflections on what's been said.
No, but I think you've got your point at the beginning about it's a route in for accountability, really, isn't it? And it doesn't mean it's their entire job, but it's a route for someone to be held to account over it and to monitor it. There's a few hands gone up now, so I'll come round those people. I'll just first though read this comment from Nikki Burgess, who's sent a comment in the chat about funding flows and with all the competing wants and needs we require to transform without changes to finance structures, how can we resource change? A lot of the money goes into acute trust on block values, doesn't support the movement of necessary funds for the transition. So how can we support commissioning to change that with financial shifts, and possibly resonates a little bit with your point, Leo, about the third sector. We see in our kind of monitoring of NHS finances that while things are tight for everyone, it's things that are outside of NHS trusts and the public sector, which, well, particularly the NHS part of the public sector at least, which tend to see the contracts shaved and sort of top sliced more than at first before NHS services. Gemma, do you want to come in?
Yeah, I first just want to commend all of the speakers because that was really impressive, and I think you've really captured the number of the types of things that we want to see in the 10-year plan. So I was just going to do two things really. One was around the funding, Dave. So that was quite a good intro to it. I mean, if you look at the Cahill formula, it really doesn't work well for these populations. It has inequalities adjustments, but the inclusion health adjustments are really unrefined. And for capital cities where that shift and change, particularly in rough sleeping, it can be very rapid and very fast. It really doesn't sort of respond in any sort of real time. And because it's invisible, because it's not ring fenced, I very rarely suggest that something should be ring fenced. But I think for a population like this, given the escalating crisis we are seeing, it's not just what's visible on the streets, but it's also what's visible in temporary accommodation and other places. I think it is a sort of bit of a national crisis. I think, a 10-year plan, as I put in the chat, it needs to be tracked with a clear 10-year schedule of investment where we can monitor what is going in and how these services are being supported to develop and plan longer term, and they don't have this sort of annual begging bowl situation going on, which just adds to the pressure on them. And then sort of the other thing just to mention, and by the way, on the funding, I think Jill's point, Jill Lane's point was really strong around, looking across departmental budgets and actually looking at some joint budgeting around that. And then I think the other bit that I wanted to mention was the need for much greater interdepartmental working. And I think the first speaker talked about prevention, wanting to go more upstream, the sort of the lived experience speaker that we heard from, made that point really well. And we keep talking about managing the crisis that's there now, and we very rarely have a chance to therefore get upstream. So I think, the sort of the relationship with the Home Office, with the criminal justice system and others, I know colleagues on the call are doing masters in those spaces, but we really need that strategy to be integrated in the same way that Jill's described with housing. We need to think about this sort of very interdepartmental nature of preventing homelessness.
Thank you, Gemma. Jill Lang, perhaps you come in next there.
Yeah, thank you. It does speak to a couple of Gemma's points, but I suppose going back to something that Tony said about inclusion health directors, and I've been sat here quietly listening, and we've been very NHS focused and talking about Wes, and he's not the only person who has a say in what happens. And I suppose that's what I'm trying to advocate for, is actually I'd be asking Angela exactly what it is that MHCLG, for example, is contributing towards the outcomes aspired to in the NHS health plan, and vice versa. My big concern is that neither department or any department actually knows what the answer is. So it comes down to colleagues on this call here in the various forums to be able to sort of advocate for what we think is needed based on the decades worth of evidence. But I suppose the point, I suppose what I wanted to advocate for and share a bit more knowledge, again, speaking back to Reese's point, is about local government. And we talk about a lot of how local government and local government being unable to meet the demands through adult social care of populations who are lucky enough to have a Care Act assessment and lucky enough to benefit from care and support. And there's a lot heard about that and talked about that, and Jill Taylor's sort of elaborated as to how our population typically doesn't even get through the door in that space. They're simply not recognised. And we also increasingly are hearing about local authorities being on the brink as a consequence of temporary accommodation costs. So again, that's in the news. What's not known, and housing is complex apparently, is that actually ever since 2010, there has been disinvestment after disinvestment after disinvestment in local government and in housing in both capital and revenue terms. And we've got local authorities now, in the absence of there ever having been a national housing strategy that thinks about health as being its primary outcome, but we've also got local authorities who have no commissioning capacity left. It's all gone. The only capacity they have in housing is focused on homelessness. There is no one thinking about, well, if we do this thing over here in the private rented sector, or if we build these social rented homes over here, or if we knock this down, or if we sell that, how does that all work out? How does that play out? Who falls through? Who doesn't get their needs met? And every time it's people from inclusion health groups. Every time, every decision that is made in DWP, in MHCLG, when there's no thought to specifically those populations who are furthest from and are in most need of benefiting from decent places to live. And it's not, my real concern going forwards is there isn't that much more funding for local government. There's some, but actually how much more of it is dedicated to replacing some of the disinvestment in housing and strategic commissioning capability at a local authority level. Health, obviously, housing's not health's job, but housing expertise in health would really benefit. There's loads of examples of how housing expertise in health and care settings makes the difference. It means that mental health practitioners, TB nurses, they can do their job, and housing people can do their job, and they're not trying to do each other's jobs. There's so many great examples. But I think I suppose just wanted to say that I think it might seem that something like an inclusion health director is an added overhead, but you don't believe how much added overheads have been lost and how much that lack of oversight, lack of accountability, lack of direction has made a difference to the widening gaps between the silos that these populations have experienced. And I haven't sworn. There you go.
Do you see, are there any sort of examples or that you're aware of, or kind of that go around the system of where local authority kind of health and wellbeing strategies have actually been able to rise a little bit above that? Is there anyone who's,
there's quite a few, and the work that Pathway did last year with Groundswell in particular, we sort of worked with some ICBs, including ICPs, including local authorities. And I think there are lots of examples, and I sort of alluded to, where local authorities working with health partners have tried to do something differently, but it's despite this bigger environment. This is despite there being a legislative framework, the funding, the security of funding. It's despite so many things and fantastic services. I mean, I led a out-of-hospital care programme that was only funded for 2 years, and not much of that remains despite the evidence saying it works. And that happens time and time again. I can point to so many government programmes over the history of time where it hasn't been sustained despite the outcomes. And but I do, in my paper, I suppose what I'm trying to do is say it's not so much, I've let colleagues kind of describe, I suppose, where the room for improvement is in the NHS. But I think there's so much room for improvement on the housing and homelessness side to meet the NHS a bit more in the middle. And I just didn't want people to kind of forget that.
Okay, thank you. And Jill Taylor?
Really agreeing with my colleagues, but maybe just to add that one of the challenges is that where we have seen investment, it has been in frontline delivery, which is really important. But what that does is it invests at that point and does nothing to change the system or the structures that enabled or disabled that frontline practice in the first place. So I think we see it with Changing Futures, an incredibly important programme that has facilitated and resourced many areas around the country to look at multiple disadvantage with the systems thinking point of view. However, the funding has been almost exclusively used to resource frontline navigators, helping people to navigate the systems that when that funding changes will still be exactly the same as they were at the start. And so for me, there's something about I also sat with that question of, do you need an inclusion health director for a minute when I heard it? And I'm not saying whether I think I agree or not, but what you definitely do need is the resourcing to enable that governance, that systemic change, infrastructure resourcing. Our Section 75 agreements are only useful if we've got the leadership to enable that to happen, the confident legal and finance teams in our organizations to build those agreements in place. So for me, there's something about recognizing that for practice at the front line to be different and sustained, regardless of the funding kind of environment, you do need that investment in leadership and governance. Otherwise, it will just continue to stop working at the front line as soon as practitioners leave, rather than being embedded across the piece. So yeah, agreeing with my colleagues.
Okay, thank you. Yeah, so we're drawing towards the end of our time, but if you've got you've been sitting on your hands, got a burning question or point, then speak up now. But it was going to that cross-government point that Jill L was raising. You know, we have been promised more cross-government working, and I think the idea was sort of mission boards, wasn't it? I haven't seen much of a kind of a preventative health wider mission board, a sign of that, dragging it and putting anything together. So there's perhaps something. It seems to me there's something about holding government to account on that commitment which they made. So before I'm going to hand over to Alex in a minute to bring things to a close and do any important announcements. But a few themes that strike me from the really impressive presentations and comments. I mean, clearly, resources are a very familiar issue for many sectors, but it was particularly striking the fragility of financing for these kind of services. And it's a really tough message to the government, isn't it? Because they feel that they're hearing about funding from everywhere. So I don't think that's an easy one, but there should be a case, I think as Gemma said, of the 10-year plan to say that we need to have a clearer strategy for kind of fencing off these resources, and maybe again, the discussion about priorities is a really unpleasant one for politicians sometimes, because they don't want to, they want to prioritize people who are, gonna kind of swing voters and things like that. But I do think there's a little bit of scope more in the discussion about neighborhoods and inequalities and proportionate kind of universalism. There may actually be scope to persuade to bring more of that into policy, to prioritize resources where they need to be towards need, and the discussion around the Cahill formula chiming with that and everything. As we said, as we were talking about earlier, the point about actually applying the guidance which already is there. Again, I think there's a spirit in some of the 10-year plan thinking about, look, this nice guidance has been there. This is clearly best practice. Why there are some things which can be done everywhere, and people can be held more tightly to account on that. So that may be another useful theme. But in general, just overwhelmed by all the excellent work and thinking that's been put into all of this. So I hope that can be be brought to bear, as I think it will be into the 10-year plan process with the papers and other work. Well, Alex, do you want to give some final thoughts and announcements?
Thanks very much, Dave. Thanks for that summary. I think it's been a really powerful, quite moving afternoon. Some of the points from colleagues on the call, as well as our paper presenters. I found myself imagining what Wes would do if he met all of you guys in the lift at the same time, whether he'd get out, how much he'd get out alive from that situation, and what he would leave with as a to-do list. Because I think there's something, as you just said, there's a just do it, isn't there? And quite a lot of what people are really pleading for. Just to share a recent experience from Pathway. So we were fortunate to be invited onto one of the groups, one of the vision groups for the 10-year plan. I went to a number of very rapid fire meetings. So it felt like a really nice open process. And that was quite a lot of very small third sector organizations in that group, which seemed right. And one of the things all those groups ended up agreeing on was this need for leadership and for values-based leadership at different levels, which I think we would include the Secretary of State in that, but not just the Secretary of State, and that being kind of cascaded down and different people being given within their terrain within their sphere of operation that kind of, it's the tools for the job and the money for the job, but then the mandate and okay, now you need to get on and do it. I think there's something we might want to reflect on how to keep that message going, that it is across the system that we need leadership, and we certainly need to see it from the top down, I think. And interested to hear the call for, I think quite a few people were nodding when, I don't know who it was, said ring-fenced budgets. I think we've experienced in our sector so often, as so many people have said, the budgets just get swiped away or are not protected, or this is not a priority. And without that ring fence, I think there's a challenge for us all in local government that particularly our transient and excluded populations can easily be seen by local politicians as not from around here and not my priority. And I think that is a parallel reason why we must call for top-down mandate in some senses to protect these populations and to make sure the investment does go towards them. So thank you, colleagues, for a really fascinating conversation this afternoon. As we said at the beginning, these papers are all online now. Dee said for people who joined the call late that we believe we've got a really nice short piece on the Channel 4 News this evening about the need for intermediate care. So do watch that. We hope it's still there by the time we come off this call. We'll be doing some social media around these papers through next week, and we're going to put them out individually and severally and together and separately and try and keep banging them out there to try and get some attention on the issues which are within them. So thanks to the authors again for contributing so much of your passion and your brains to setting out some really clear asks. I also don't want to share, colleagues, that we have our program for the Pathway 2025 conference is now out and looking brilliant. Really, really interesting set to speak. Some international speakers coming from around the world to come and share some of their perspectives, which is always fascinating. So that's the 13th and 14th of March. We were learning this morning that tickets which we've not had before, are looking like we might get close to selling out. So I don't want to panic anyone who hasn't bought their ticket yet, but please do have a look. There's a very, very strong program there and tickets available. I think that was it from me. Just finally, just thank everyone again for their time and their contribution. We've recorded this, and we're going to be, again, people who spoke, the speakers will be using little clips, I think, on social media, but also we'll be putting this up for people who couldn't make it today to come back and review what has been said. So we'll share that with everyone who's here, and you can use that link again if you want to. If there's something you saw someone say today you wanted to share with a colleague on your own networks, then you'll get a link through which you can do that too. So yeah, thank you all. Thanks to everyone who came along. Thanks to everyone who contributed to the conversation this afternoon. Have a good evening, everybody.
Thanks, Alex, and thanks a lot to everybody from me as well. It's been absolutely fascinating and really interesting to hear. So thanks to Pathway for inviting us all along and hosting, for everybody for dialing in, and especially to the speakers and paper writers who clearly put a lot of thought and put their case across extremely well. Bye.